I would like to introduce our first speaker, Dr. Waugh. This is interesting. So he gave a talk to the emergency department at Children's about a year ago, and in the middle of his talk, I did something I very rarely do, which is I took out my phone and I typed an email to him, inviting him to give a talk here because I was so impressed with his style. And he graciously accepted. And then I found out this morning that he is no longer at Boston Children's. He is the director of movement disorders at Children's Medical Center in Dallas. So he's flown in from Dallas because he's such a wonderful person, didn't cancel on me, to give this talk. He was the medical director of pediatric movement disorders and deep brain stimulation at Boston Children's. He received his BA in chemistry at Washington University, PhD in neurosciences at the University of Texas, his pediatric residency at Children's Medical Center in Dallas, his neurology residency at Boston Children's, and his fellowship in pediatric movement disorders at MGH and Boston Children's. And he is going to be talking to us about abnormal movements in children.
I think the first thing I should tell you is that there are physicians who are seeing pediatric movement disorders here in Boston. My two fellows have now taken over the practices at Boston Children's and MGH. That's Claudio Guzmao and Maricela D, respectively. So they will do a far better job than me, I am sure, of taking care of your movement disorders patients. The reason it's recognizing abnormal movements, as opposed to, here's a soup to nuts view of movement disorders, everything A to Z, is that I used to give that talk. And I realized afterwards that a lot of physicians would come up to me and ask me questions of, should I send this gene panel, should I start this medicine, et cetera. And over, my colleagues, even fellow neurologists, were getting the phenomenology, the style of movement, the nature of the movement wrong, and therefore which medicine to use or which gene test to send, et cetera, that was wrong. So we needed to go back to the fundamentals of exactly how do you describe movements and how do you recognize this movement from that movement. So this talk is all geared around building up structures for you so that you know when to recognize dystonia from chorea, from myoclonus, et cetera. So I have no relevant disclosures. The people who give me money do so for research, not for clinical care. And I'll start with a video example. This is a patient whose chief complaint was actually that she was having a hard time eating. So, and the description of her difficulty eating was very important. Mom said that she would do fine when the food was on her plate. She would do fine when she would pick up her fork, but as soon as she picked up her drink or when she picked up her sandwich, things would just fly apart. She would spill. The parts of her sandwich would literally disintegrate. So she had motor delay. She had this strange history of hemiparesis in the first year of life, which was hard to make sense of. I was sure I was going to find a dystonic cerebral palsy on MRI. Didn't find that. And now she was having progressively worsening difficulty with running, riding, eating, and drinking. Let's look at this young girl. Now, I need to give you a trigger warning. This girl is so cute, you may just fall out of your chair, so just be ready. So you can see she's on target for several, and then she'll miss. She's on target for several, and then she'll miss. And then it'll be the hand, and then the shoulder. There's multiple places where she's having these jerking movements. It's helpful in video movement disorders to slow things down and get to see it, try to break it down into its component parts. And you see, oh, there's the jerk to the side. So when her body jerks to the side, her finger pulls off target. That's why she misses. So this is our starting point for discussion. I'm going to go through sort of our structure for how we describe these movements and then come back and talk specifically about this girl's movements and break them down for you. So let's first think about how movement disorders are different. I mean, there's lots of ways that a person's movement can be abnormal, and I've listed just some of the kinds here. But in contrast to these many ways that movement can be abnormal, a movement disorder is something a little different. A movement disorder originates centrally. This is always a brain-based problem. There are a few times when you can have movement disorders that originate in the spinal cord, but they're very rare relative to the rest. They never originate peripherally. Movement disorders are more than just not doing something well. This is not a failure of fine-tuning, a failure of execution. This is an added on. This is an emergent property. Most of the time, movement disorders result from abnormal networks. That is, it's not just that you localize a lesion to spot X. It could be X, Y, Z, etc., along a circuit of abnormalities. And movement disorders can be too much, which we call hyperkinetic, or too little, that we call hypokinetic. So what do I mean by movement disorders localized to a network? Well, what we mean is that it denotes that the network itself is functioning abnormally. And in some movement disorders, that can mean that a spot is wiped out and therefore not participating in the node. In other places, it could be that a different node is overactive and so is driving the network in an abnormal way. So this is more than just a routing problem. It's not just that information isn't making it from A to B. This is an emergent property. So it's something added to, not just something performed poorly. This is one of my favorite movement disorders basic science research studies. So this was a study using PET imaging in patients with one kind of dystonia. And they showed that in patients with dystonia, they have places that are too hot, that are overactive in yellow, places that are underactive in blue. But it's really this combination of all of them together, these abnormalities, both positive and negative, that adds up to the dystonia pattern. And each type of dystonia has this sort of unique pattern. So if step one in our process of characterizing abnormal movements begins with phenomenology, so you want to describe the patient based on what is it too much movement or too little, hyper or hypokinetic, what type of movement it is, and I'm going to give you the 5 canonical categories of hyperkinetic, the 1 canonical category of hypokinetic movement disorder. Then describe whether it's one movement in isolation or whether there's multiple types of movements that are layered on top of each other. You know, one of the adages I always say is that if a picture is worth 1,000 words, a video is worth 1,000,000. I can slow it down. I can watch it 10 times. I can watch it now compared to when I stop medications. You can send me a video from your cell phone, and I can make a diagnosis from the slopes or in Cabo. As if, I wish. But the opportunity to do video consults in movement disorders is one of the great strengths. So I love it. It's like Christmas morning when I open my inbox and somebody sent me this weird video that nobody can figure out. So please, I'd love to see them. So in the young girl that we saw, things that I didn't show you are that her writing started off clumsy, but then became progressively more and more cramped and sloppy. And it was consistent with hand dystonia. When the person starts off with difficulty control, but as the effort progresses, the control just becomes more and more difficult. She also had posturing of the left foot while she was walking, and her right hand, again, progressively distorted. So these were variations of dystonia. So for characterizing the phenomenology of this young girl, then what you saw in the video were these rapid jerks. That's myoclonus. So she had generalized pattern of myoclonus. She also had dystonia. Again, I didn't show you that in the video, but just by description. So she has both myoclonus and dystonia. Now, movement disorders neurologists are not the most clever in nomenclature. So we just call this myoclonus dystonia. Helpful name, right? So she actually has the classical DYT11 myoclonus dystonia. Let's talk about each of the categories of hyperkinetic movement disorder. So in the great tradition of scatological mnemonics, the way that I remember the 5 are CTTMD. So chorea, tics, tremor, myoclonus, and dystonia. Let's talk about each of these in turn. So chorea is often described as being dance-like. Now, don't think about dance like the way I dance. That's more like Parkinsonism. But chorea being dance-like means a flowing, a continuous flow of movement from one body part to another. Oftentimes with chorea, there's not a blocking of what the person wants to do. They can still do the volitional actions. It's just the chorea rides on top of that. One of the greatest illustrations I've seen of this was a patient that I saw with Huntington's disease who had just florid chorea, was moving continuously. But when asked by the examiner which medications he was taking, reached into his pocket, pulled out his pill bottle, threw it in the air, bounced it off the top of one hand, caught it in the other, and opened it, all while floridly being choretic. So chorea doesn't stop you from doing those things, it just rides on top of. How about tics? We could spend an entire hour just talking about tic disorders, and that's something that's tough in a pediatric movement disorders talk because we would then not have time for all the other things that you otherwise wouldn't recognize. So I think it's important though to talk about tics, if only briefly, because it's almost always in the differential. So what to think about with tics? So tics are these rapid, purposeless, repetitive movements. It should be repetitive on a scale of weeks to months. So a person might do the same tic over and over for a period of time, and then it'll evolve into something else. So maybe it's excessive blinking now, but in 2 weeks from now, it's going to be nose sniffing. And 2 weeks after that, it's going to be touching the ear, some other purposeless type of movement. The rules I keep in mind for tics are these. It should be suppressible. that the kid should be able to keep it in for a brief period at some level. Now, if a person has severe tics, they may only be able to keep it in for a few seconds, but that element of suppressibility is key. The other movement disorders are completely not suppressible. So even if it's suppressible for a few seconds, that's a key thing in your differential. If it is evolving, again, the movement should change in nature over time. It should change in space, so the part of the body involved, and it should change in terms of the timing. Which movement is now versus is the lead versus which is the follow. So all those things should evolve in time, space, and nature. The tics are unique in having a premonition. A person can tell you when a tic is about to come on. They can tell you when it's going to be a bad tic epoch. So they can say like, I know for the next 30 minutes, hour, whatever their span of time is, tics are going to be a big deal for me. And there should be associated factors. So you should, by the company that it keeps, you should be able to recognize tic disorders, be it an increased likelihood of ADHD, obsessive compulsive disorder, anxiety, depression, all these things either in the individual or in the family. So if a person has all four of these things, you don't need me. You don't even need a pediatric neurologist. These are pretty easy diagnoses to make. If you got three, you probably don't even need a pediatric neurologist. The tough thing is what do you do if someone has only one of these factors? That's when it really you got to really define down exactly what we mean. I find that a dollar bill is one of my most useful tools because a kid who says, no way can I suppress this. If I put a dollar bill on the table and say, for 10 seconds, you think almost any kid, if they work hard enough, can suppress if they have a reason to do so. How about tremor? So the key thing to think about with tremor is that it is oscillating. There has to be a point around which the movement oscillates. It is rhythmic, and you should be able to identify a fixed point around which the oscillation moves. Now that might be a single joint, but it might also be a collection of joints, an axis, like the neck. So you should be able to pick out those three features: the point around the oscillation, the rate of the rhythm, and the direction of movement. Those are all things to look for in tremor. How about myoclonus? Well, we saw a good video example, but what to think about with myoclonus is that it is fast. It is fast. So if you put EMG on a person and say, make the fastest movements you can, that's still not as fast as myoclonus. So myoclonus happens faster than any volitional movement. So it is shock-like. It's like they have been jerked suddenly. There are tics that are myoclonic in nature, and so that's where it's really key to be able to distinguish, is there any premonition? Is there any suppressibility at all? If that's the case, then maybe this is a myoclonic tic as opposed to a true myoclonus. And dystonia. So I've got 3 kids. I'd swear I love them all the same. They are unique and special, each in their own way. I try to feel the same way about the movement disorders, but dystonia is just so interesting. It's just the best, and I can't honestly tell you that I don't love it the best. So what to look for in dystonia? So with dystonia, one of the reasons why I love it so much is that it is a confusing disorder because it looks so strange in many cases, and it can be confused by other things in such an easy way. So what to look for in dystonia? So essentially the problem in dystonia is a difficulty in turning off. So when muscles are activated and you're desiring to do a very limited set of actions, those muscles remain active too long and are not able to switch from, say, a push to a pull. So a person reaches out for the coffee cup, maybe they can grasp it, but the motion forward and the grasping motion hand don't stop. So then they can't bring it in, and then they have a hard time tilting the wrist. And then the motion from the desired muscles spreads to surrounding muscles, and they get a progressive contorting type of action. That's how you recognize dystonia, that co-contraction of both agonist and antagonist muscles. What else? So those are the 5 canonical categories, and then we start to add layers on top of each other. So there are things called the paroxysmal dyskinesias. Paroxysmal, of course, meaning sudden and irregular, and dyskinesia meaning that there are multiple movements on top of each other. Dyskinesia just meaning abnormal movements. So these overlapping different movement categories fall under the category of dyskinesias. Motor stereotypies are something that all of us can see in our clinics every day when we go to see our kids at school, at the malls. Motor stereotypies are everywhere. I see this in departmental meetings all the time. They may go away, but oftentimes, they just keep on going throughout life. And there are many developmental movement disorders that are absolutely normal. There are at least 12 distinct disorders where really what you need to do is recognize it so that you can reassure that this is a normal thing. So for example, benign neonatal sleep myoclonus. Often forgotten in this category are the functional disorders, which we used to call conversion disorder. So this set of disorders are actually far more common than any other disorder I'm going to talk about today. So they should always at least be in the differential. They're often as disabling as their organic counterparts, and they are readily identified by physical exam measures. These absolutely are not a diagnosis of exclusion. This is a diagnosis which you recognize on site. So if step 1 is the phenomenology, step 2 is defining the distribution of the movements and their timing. These give you very important clues. So the movement disorder can be focal. It can involve just one part of the body, as illustrated here in Reiter's cramp. It can be segmental, so 2 contiguous body areas, like this facial dystonia and cervical dystonia, affecting both face, shoulder. Or it can be generalized, as is seen here. This is actually a young man with DYT1 dystonia, the first of the dystonia genes that was found at MGH. So this pattern of onset and then spread is very characteristic for certain kinds of movement disorders. So a few years ago, I made a table of all of the genetic kinds of dystonia and where they commonly start and where they spread to, and put that on a homunculus for each disease. And it's very clear that if you find a 12-year-old kid with a leg onset that then spreads to the body, that is DYT1 until proven otherwise. But if it's a face onset that then spreads to the arm, that's likely DYT6 until proven otherwise. So there are these patterns of onset and spread that are very characteristic. It's true not only in the age at onset, but the timing in the sense of when within the day. There are some movement disorders that only come on first thing in the morning, others that come on late in the day. Some of them are induced by quick actions, some of them are induced by prolonged exercise. I'm not going to pin the responsibility on you of pinning down each of these timing, but just know as you're thinking about how to characterize that timing matters a lot. So get these details, it'll really help you to figure out which category to go into. So for the example I showed you of this cute little girl, she had bilateral involvement, she had trunk involvement, upper and lower extremities, so we would call that a generalized pattern. She didn't have a clear progression. So this is a key thing I actually saw her as a second-year resident and then followed her for a while into my fellowship. And initially her mom said, oh my goodness, this is getting so much worse. But when we looked back at the actual frequency of the movement, the nature of the movements, their amplitude, it's not that the movements became worse, it's that we expect more from a 5-year-old than we do from a 3-year-old. If a 3-year-old spills their drink every time, we're frustrated, but we don't think that there's a problem. It was only when this girl's myoclonus led her to spill at school, and she started to become teased about it, that this became a problem needing referral. So her myoclonus was stimulus-induced. When she started to do finger, nose, finger, you could see that it increased the frequency of the movements considerably, and she had task specificity to her dystonia. Again, I didn't show you that in the video, that's by history. But when she wrote and when she walked, that elicited the symptoms. So step 3 of our 3-step characterization process for movement disorders is incorporating the first 2 and approximating your etiology. So by this point in the phenomenology circuit, you've got a good idea of what type of movement disorder it is. You've got a good idea of the distribution within the body and within the day, and that lets you make a short list of possibilities. Now, one monkey wrench that gets thrown in here is, what if movement is not the only symptom? What if this is part of a broader encephalopathy? Is there concomitant epilepsy? Is there a cognitive decline or school failure? These are things that definitely take the differential in a completely different direction. So it's often the case that movement disorders can be secondary to another disorder, degenerative disorders, stroke, etc., or they can be primary, the movement disorder on its own. So that's often going to require an MRI or further testing. But if you can get to this point where you're saying, I think it's this category, I'm going to do a limited number of tests to probe my hypothesis, then you're in a good spot. Because this is where you've got a limited differential that you can work through iteratively instead of the broad world of possible testing. Let's do some specific examples of each of the canonical movement disorder categories. So this is not projecting well, unfortunately. What I'm trying to show you is actually a lithograph from the 1880s of 3 boys with Sydenham chorea. and they are contorted in various positions. And it begs the question, how do you show movement before the era of online videos? Well, journals tried to show lithographs and show sort of line drawing of movements. And looking back at those, they do a surprisingly good job of capturing the essentials of movement. So this is a nice figure of lithographs that you'll have to just take my word for. So again, chorea is dance-like. It is continuous, a flowing movement where the abnormal movements start in one body part and then flow to other body parts successively. The way to recognize chorea is to watch it in 10-second bins, to train your eye to think, what am I seeing now, and now, and now? And can I predict with the next epoch what's going to come next? With chorea, you can't predict it. It's random. The nature of the movement, the body part involved, may be similar. It may be more right than left, for example, but it's going to be a different sort of movement. So it's important to distinguish this from akathisia, that sense of internal restlessness that may make a person be very wiggly. So there's a very important test to be able to distinguish between chorea and akathisia. Does anyone know what that is? Mark's heard this before. So do you remember? Do you remember what the test is? You say to the patient, "Are you restless?" That's how you distinguish between akathisia and chorea. That internal restlessness for a person with akathisia, they will have been holding it in, they will have been fighting it, and when you ask them, they'll say, "Absolutely, it's driving me crazy." The person with chorea will say, "What? No, I'm not restless. I just wish I could stop moving." There's no sense of internal drive with chorea as opposed to akathisia. So most important clues on your physical exam are signs of motor impersistence, which essentially is the inability to sit still, the inability to maintain a fixed position. I'm going to show you some examples of these, but they're called jack-in-the-box tongue, milkmaid's grip, and the touchdown sign. So with creative names like that, clearly these were not made by a movement disorders neurologist. So with chorea, you should also find hypotonia. It's almost always the case that if I diagnose chorea, I'm also going to find hypotonia. The exceptions to that are very unusual but important, and those are ones that honestly, like I see maybe once or twice a year. All right, let me show you an example of a boy with chorea. So the excessive movement is what strikes your eye. But essentially what this boy has is the inability to maintain a fixed position. This is classic for chorea. Let me show you one of what these physical exam findings look like. So jack-in-the-box tongue is so named because in the classic jack-in-the-box, the jack always had his tongue sticking out. And the jack-in-the-box tongue is supposed to evoke this tongue darting out and in, out and in. What that really is the inability to maintain a fixed position. So you can get that not just from chorea, but because of embarrassment. So if I'm testing this in a teenage person who doesn't like to stick their tongue out at an adult, they'll sometimes fail because of embarrassment. So I stick out my tongue too. And I say, who can do this longer? And then just see what their tongue looks like. So you're really looking for any sort of abnormal movement, be in, out, left, right, up, down, etc., that is not just a fixed position. That's the jack-in-the-box tongue. How about milkmaid's grip? So this is my old kitchen in Medford. This is my wife holding my fingers. And what you're looking for in the milkmaid's grip is the patient is holding your fingers, and you're providing just a bit of back traction so that they have to hold on a bit. And if they have chorea, they can't maintain a fixed grip. So they will relax and then have to squeeze again to recapture. So you'll feel this intermittent grip and squeeze, grip and squeeze. And so that is what you're looking for in the milkmaid's grip. If it's just a continuous gentle grip, that's not chorea. How about touchdown sign? So if the patient has their hands above their head, you'll see a deviation either medially or a dropped shoulder. Either one of those is positive for the touchdown sign. Let's see an example. So this is jack-in-the-box tongue in the same young man I just showed you who had chorea. So you can see that this is a not darting in and out, as many of us were taught. It's actually more a left to right, up to down sort of abnormal movement, but this is the classic jack-in-the-box tongue. Let me show you another example of an idiopathic chorea. Now this is a young woman who has really a Huntington's disease-like presentation, starting with some cognitive decline and ADHD, starting to have progressively more and more severe chorea, and then developing mood lability that we call pseudobulbar affect. And the thing that I think is most striking about this young woman is that despite the floridness of her chorea, she's still able to do things like open doors, walk down the hallway, write. She can incorporate her volitional movements despite the fact that she has just very robust chorea. You can see how perilous it is to try to define things as bizarre versus not when it comes to movement disorder. This girl's movements are absolutely bizarre in nature, but they are clearly organic. So that distinction between functional and organic just by bizarreness doesn't work in this arena, and I would say it doesn't work in many other arenas too. Let me show you what her handwriting looks like. This is just her writing her name. This is when she was 11. This is my 8-year-old normally developing daughter writing the same name, just to give you some idea of scale for a typically developing child. So her writing is much bigger. She's not able to control the space, and because of her progressive cognitive decline, she's not able to use the space wisely. So an 11-year-old should be able to reach the end of the line, know to bring this word down to the next line. I asked her what she wanted for Christmas, and she said a big horse, and trailed off down the side. So this is another example of cognitive decline. So let's talk about tremor. Again, tremor really has to be oscillating in nature. It has to be rhythmic. You should be able to pick out a frequency and say this is a 3 to 5 hertz tremor or a 10 hertz tremor. If it's varying on these, if it moves to a different place or it changes frequency, that's probably not tremor. You should be able to figure out a fixed point around which the oscillation occurs. You should also be able to identify the position at which you see the tremor the most. Is this a tremor that's most at rest? Is this a tremor that is involving posture? Is this something that you only see with movement, an action tremor? It is uncommon in kids, but because people know what to call it, this actually is about 10 to 20% of what I see in clinic, at least as a chief complaint. But because people who are not medical individuals don't have a vocabulary for abnormal movements, what they mean when they say tremor is, my kid is moving funny and I don't know what to call it. So I would say maybe 1 out of 3 of the cases where someone says, I think I have a tremor, it's actually tremor. The other 2/3 are something else. When you see these patients in the hospital, when I get a consult for tremor on a hospitalized child, I'll tell you 99 times out of 100, my recommendation is to do nothing. Because kids in the hospital who are receiving many, many medications will have tremor for a variety of reasons that don't impact the care in the hospital. It's something that can be either worked up as an outpatient or something that's just a side effect of the severity of their illness, the number of medications they're on. So I very commonly advise, let's back off and do less instead of more when it comes to inpatient tremor. So this is a young man who has autism and tremor, and I want you to think to yourself, where would I characterize, like what's the point of oscillation? What's the state dependency, rest versus movement, and what kind of frequency? So you can see that at rest, the tremor is quite fast. It has kind of a pill rolling characteristic, but as soon as he reaches the point, it resolves completely and then comes back when he puts his hand at rest. So this is a rest tremor, fairly fast. This is probably, I would say, 8 to 10 hertz. Now, I've seen enough tremors now to have a feel for how fast they are, but it took me a while to get to that point. How can you get to that point? Well, there's a great app put out by the U.S. Geological Survey that is called iSeismograph, and it literally is for citizen scientists to be able to track earthquakes. I use it to track tremors. You just put your iPhone in the patient's hand, you press start, and let it run for 10 seconds, and it will give you a spectrographic analysis of the tremor. So you can get a frequency and a direction of movement. It's a great app. It's free. So it's important to know, too, when something is not the movement disorder in question. So I'm going to show you 2 examples of when patients came in saying, I've got a tremor, help me, and it turned out to not be tremor. And I want you to think about why this is not tremor. So it's present at rest. It's present with action. She's got some AB and adduction of the fingers, a little bit of flexion extension of the fingers. She's got a little bit of wrist rotation. There's a little bit of flexion extension there of the digit. There's not really any change with the state of movement, rest versus action. It changes axes, and if we slowed this down and really look closely, I could show you that there's also a change in the frequency. So this is something called poly-mini myoclonus. This is myoclonus that is very small amplitude, but is so frequent that it is confluent and leads her to just look wiggly. So this is an entirely different movement disorder with an entirely different treatment. There's another example of when a person said, I have a tremor, and it turned out to not be. Try to characterize and think of what this movement might be. Chorea, very good. He is trying to maintain a fixed position and can't. And the motor impersistent is your hallmark of chorea. Exactly. So let's talk about myoclonus. So again, myoclonus is very, very fast. It's also brief. It is on and off just like that. And it is a non-suppressible movement with no premonitory features. So the person should not be able to tell you, I know it's coming and I got ready. They shouldn't put their glass down and avoid spilling. That's a different phenomenon when there's some premonitory feature to it. Myoclonus can happen in isolation. It could be a primary myoclonus, or it can be a symptom of many diseases, myoclonic epilepsies, degenerative syndromes, etc. Now, all of us have myoclonus every now and again. When we have too much coffee, it's grant deadline time, and our eyelid is just driving us crazy, and our eyebrow is going crazy. That's a type of myoclonus. Hiccups are a type of myoclonus. As you're falling asleep and your body has a quick jerk, that's a type of myoclonus. So I always find it's helpful to families to be able to describe some of these physiologic myoclonuses so they have some framework to say, like, what their child is having is an exaggeration of something that all of us have. Now, there are, again, developmental conditions where myoclonus is both robust, frequent, and entirely benign. So benign universal myoclonus and benign myoclonus of infancy are just two distinct disorders, both of which should lead you to reassure. Now, I have before seen myoclonus come as a question of ataxia. If myoclonus is so robust that it pulls you off axis, the way to know that it's not ataxia is that the person doesn't actually fall despite looking like they are bound to. Let's look at an example of myoclonus.
Yeah. Get your drink, boo-boo. Look at your drink. Is he missing it?
So you can appreciate the action-induced nature.
Can you get your drinks?
The more he tries, the more robust the myoclonus is. It's a generalized pattern.
Try again. You did it. Take a drink, honey.
And he hasn't had facial myoclonus until he starts to try to use his face.
Can you get it
And
in
he
your
can't
mouth?
keep it in his mouth. He has to bite
Can you put it in your
down
mouth?
with
Is
all his
that
strength
it?
to just keep it in place.
Try again. Come on, honey.
So that's the most robust myoclonus I've ever seen. This is a young man who has intense action-induced myoclonus. So this is him in my colleague, Dr. Skellig-Stone's office for our deep brain stimulation conversation. And this is our eval visit. Now you look at that kid and say, why would you do surgery on that kid? He doesn't move at all. But as soon as he starts to write, you see the myoclonus come into play. Now, he's the kind of guy where, depending on what he wanted to do with his life, this level of myoclonus might have not been troubling enough to risk a brain surgery. But his goal was to go to art school. And he actually made very impressive art, but he did it by locking both hands under his chin and drawing like this. And it was amazing what he was able to do within that limitation. But after getting deep brain stimulation, his myoclonus has reduced by, he estimates, about 95%. He's now in art school. He's doing great. Let's talk about dystonia. Again, the coolest movement disorder. So with dystonia, it's actually a failure of relaxation more so than an addition of movement. So it's often painful. It often leads to these twisting, distorting postures. If a person has dystonia long enough, they can get a joint contracture, just like if they had spasticity. So if you're seeing it early on, it's easier to tell it's dystonia versus spasticity versus something else. If it's been present for years and years, you may just be in this boat of kind of being stuck. So the co-contraction of agonist and antagonist are one of these core features. The overflow of surrounding muscles is another important clue. So if you see the person doing the actions that trigger their dystonia, and you start off with sort of a little and then it spreads and contorts and twists, that's probably a dystonia. The presence of a triggering action is another really important feature. So if a person says, I can use chopsticks just fine, I can reach to the doorknob just fine, but using those same muscles when I pick up a pencil, that's when dystonia happens. So that triggering action is a really important clue, not only that this is dystonia, but also sort of which muscles you might inject for Botox, what types of dystonia it could be. So eliciting those triggering motions are a really important thing for dystonia. Importantly, the motions of dystonia are normal in between those triggering tasks. A person might have entirely normal tone until the dystonia kicks in, as opposed to something like spasticity where their tone is always abnormal. So dystonia in all of its forms, that is, when it's primary, when it's secondary, when it comes in Parkinson's disease, etc., when dystonia is the third most common movement disorder, it's just hidden in all of these other little camps, so most of us don't recognize it. Let me show you some examples of dystonia. This is a young man whose family is very athletic together. They go on runs every night. You can see that left ankle is doing this weird circumduction thing. And 1 month later, you can see it even more robustly. Again, that left lower leg is doing this strange movement. And then over just a few months, he progresses from only leg symptom to a generalized pattern. So in terms of dystonia, this is a very rapid progression. Progression from focal to generalized in only a few months. And I told you before, if you draw out the homunculus of a person and where the symptoms start, where they spread to, this boy, before we did genetic testing, I was 99% sure he had DYT1 because that's what it does. It starts in the leg, spreads to the body in the pre-adolescent phase. You can see that with his writing, he becomes progressively more and more cramped. He's drawing serial L's, just L, L, L in serial loops. And as he goes from left to right, he gets harder and harder to keep them distinct. His motor control progressively falls off. So the movements of dystonia are often bizarre. Let me show you a young man. Ironically, both of these young men are from Maine.
He's a very good ball.
Okay. So
Backward or forward?
let's start off. And this young man's symptoms started off in his right hip as a flexion movement. He simply can't keep his leg down. It wants to pull up like this. So as he's trying to walk, you'll see him trying to hold his leg down.
He's a very good ball.
Okay. So
Backward or forward?
let's start off with walking forward. Okay. Now he's a bit of a ham, but in between that, you can see how much this dystonia limits his walking. If hopping is easier, you can try to hop too. Okay. Now, why don't you walk back to us in the way that's easiest for you? So he has found out that if he walks backwards, the dystonia becomes much less. It doesn't take it away, but it does become less. But he's actually figured out another way to get around that's even faster, and it's what he calls the bear crawl. Now, do your bear crawl for us.
That kid is fast.
Very fast.
You think you're going to have to start again because I don't think I got any of that. You were so fast, you were just a blur.
Okay. Now, in his school, he was able to get around just fine doing the bear crawl. But because his hands were on the floor, the school was afraid he was going to get stepped on, and his hands were getting dirty all the time. So the school told him he couldn't do the bear crawl. At that point, he became wheelchair bound, and he developed a joint contracture. So this is one of those classic cases where the child is giving you so many clues as to what's wrong, and they are adapting in such a way that makes life work for them, and we adults take that away from them. So, ironic. So dystonia and chorea each have abnormalities of writing that are characteristic and are important to compare. So on the left, we have a patient who has a dystonic cerebral palsy. He's writing his name, and you can see that at the top line here, I mean, this is a physician quality handwriting right here. But with every line, it becomes more cramped, more difficult. This is a classic pattern for dystonia. In contrast, in the right, we have a young woman with chorea, and you can see that it's far from neat handwriting, but it doesn't progress over time. And you can see that if you track any one letter, like if you focus in on the D's in this today, it's fine, it's fine, it's fine, and then there's this loop introduced. And for most of the letters that she writes, you'll find that there's many iterations where it's fine, and then there'll be an introduction as the chorea adds in a little bit of movement. Let me show you what dystonia can look like when it's focal. This young woman had dystonia limited just to the right hand, and she has flexion of the second, third, and fourth finger. And the splay of the first finger is actually her trying to fight the dystonia to push out as hard as she can. And that combination of splay and contraction is a very common thing with hand dystonias. In children, though, dystonia is typically generalized. Now, this is a young woman in quite some distress, so it's a little bit difficult to watch. This woman has dystonic cerebral palsy. She's in the midst of a dystonic crisis. She has extreme opisthotonus, extension of all of her limbs. This is a true medical, a true movement disorders emergency. There are not many of those movement disorders emergencies, so we have to pay a lot of attention to the few we have. And the reasons why dystonic crisis can be so problematic is that a person can have fracture, They can have rhabdomyolysis and muscle breakdown, secondary organ injury, dehydration, hyperthermia, etc. So in the class, before we had ICU levels of care, this was the cause of death for most children who had generalized dystonia, because eventually they would fall into dystonic crisis. We actually had a patient at Boston Children's 6 months ago who presented with DYT1, this classic genetic form that usually is fast progressing, but you've got time to work it up, presented in dystonic crisis as their first manifestation. So it can happen even in primary dystonias. I often get this question: how do you tell spasticity from dystonia? Both of these are muscle stiffness disorders. How do you tell them apart? Well, the reality is that they really just look very different. And once you've seen enough examples of dystonia, I think you'll see that these really just look like very different disorders. But what are some specifics about how they're different? So with spasticity, the severity of the stiffness increases with the rate of movement. If you extend the legs slowly, you'll meet resistance, but it will often be much less than if you extend the legs in a fast jerk. Dystonia doesn't care about the speed, it cares about the type of movement. So it's, again, back to our analogy with the hand, it's not that they you can manipulate the hand all you want at whatever speed, it doesn't produce it, but as soon as they pick up the pencil, that's when the dystonia will kick in. With spasticity, you've usually got large body areas involved. This is like a hemi problem or an entire limb problem, whereas with dystonia, it can be very focal to only a few muscles. And with spasticity, you can almost always pin it down to something. There was a known injury, there was a suspicion of birth trauma, etc. Whereas dystonia is almost always idiopathic. It's often on the background of being stable function over years, either normal in the case of a primary dystonia, or in the case of, say, cerebral palsy, a stable spastic cerebral palsy that then one day develops this change of dystonic cerebral palsy. So just try to see a lot of cases, because truthfully, these look very different. I mentioned before that dyskinesia is a term that is imprecise by design because it allows us to bring in these disparate categories of overlapping movements. So the key thing with dyskinesias is that they are intermittent, they are involuntary, they shift from part of the body to a part of the body, and they very often have this strange or bizarre character. Now, when we say dyskinetic cerebral palsy, we mean something different. So these are terminology that's important to cleave the two. When we say dyskinetic CP, what we're really saying is that the person has some dystonia and some chorea. Many people will use the term dystonic cerebral palsy to make this distinction, but in the literature, you'll often see dyskinetic cerebral palsy. There are actually 3 different subtypes of paroxysmal dyskinesia that are important to talk about, and they can be distinguished by 3 questions. How often does it happen? How long does it last when it happens? And what was going on just before? So let me show you some examples. So back in my residency at Boston Children's, my clinics were on Tuesday. This young man's symptoms started on Friday. This video was taken on Saturday, and they had come to see me by the following Tuesday. So this was an explosive onset of a new type of movement on an entirely normal background. And on this Saturday, they estimated that it happened 50 times that day. So when I saw them on Tuesday, they were terrified. So let's see what these movements look like. Mom says that she whipped out her camera within seconds of it starting, so maybe 10-second duration at the start of the video. You can see it's right greater than left, but there's bilateral involvement. It is leg, arm, and face. And it starts to ease up a bit. He's starting to feel a little more comfortable. He's still a little contorted. But now he's done with his younger brother. Get off me, leave me alone. Totally back to normal. So total duration, roughly 45 seconds. And this was the nature of all of his episodes. Very many throughout the day, but very quick. This is absolutely characteristic of something called paroxysmal kinesogenic dyskinesia, PKD. So if it happens many times in the day, happens very fast on and off, on an otherwise normal background, this is PKD until proven otherwise. We started carbamazepine on that Tuesday. I see him once a year for med refills. He hasn't had an episode in 5 years. So this is one where knowing the right medication and making the diagnosis is absolutely curative. This is another young man who he had a similar type of totally normal background. He actually was the cornerback on his local football team, and he found that when he had to do explosive takeoff from the line of scrimmage, that he was having these PKD movements, and that was making him slower than the competition. So his main complaint was that he was worried he was going to be cut from his football team. But he was able to elicit one for us in the clinic. That's it. Yep. There he goes. All right, it's done. So that quick, 10 seconds, and that was the entirety of his episode. Now this is, again, paroxysmal kinesogenic, meaning that the movement itself elicits the abnormal movement. So this can happen when a person starts the movement. It can be when they are planning to have a movement. So if a person is seated and they recognize I need to get up, that just starting to rise can trigger it. So it's not just sort of the movement happens and then the dyskinesia starts. The other categories of paroxysmal dyskinesia are paroxysmal non-kinesogenic dyskinesia, PNKD. So it is an absolute contrast. So if PKD is very fast many times during the day, PNKD might only happen a few times a year, but it lasts hours or days. So that same sort of twisting, contorting movement lasting hours. So understandably, those patients end up in the ER and they say this crazy thing happened a year ago, but it hasn't happened since and nobody knows what to do with it. That's usually PNKD. How about hypokinetic movement disorders? So there's really only one, Parkinsonism. And we say Parkinsonism because it's not Parkinson disease, but it looks a lot like Parkinson disease. So there's 4 features of Parkinson disease that if you have 2 out of those 4, you can diagnose Parkinsonism. So slow movement, bradykinesia, having rest tremor, having velocity independent resistance to movement. So unlike spasticity, where the faster you move, the more resistance, with rigidity, it is like what they commonly describe as a lead pipe phenomenon. So no matter how fast you move, it's the same degree of resistance and in all phases of movement. And if the person has postural instability. So any one of these features can diagnose, any 2 of these will diagnose Parkinsonism. So idiopathic PD really does not happen in the below the 20s. So if you see a kid that you think has Parkinsonism, look to something beyond, the typical idiopathic Parkinson differential. So it's in my experience, probably 90% of the time it's medications. Sometimes it's due to a degenerative syndrome, and you're seeing PD, the Parkinsonism, as a parallel phenomenon to their larger cognitive decline. So there are certainly cases I see with Parkinsonism. They're just not very common. Let me show you a case of a video consult I did from Guatemala. This was a 20-year-old woman who had been previously healthy until about a year before. And there's a team from the Brigham who goes down and delivers medical care in a just incredibly compassionate, heart-driven clinic down in Guatemala. And this was one of their patients. You recognize the stooped posture, the hand held in a roughly 5 hertz tremor, masked faces. This is a perfect idiopathic Parkinsonism, so a Parkinson disease. So my guess is that she probably has one of the inherited Parkinson disease genes that leads to a lower age of onset. Parkin would be one of those. We started Cinemet, levodopa on her, and all of the symptoms faded away. So as with all cases of Parkinson disease, she's likely to have 5 to 10 years of honeymoon with using simple levodopa, followed by progressive loss of efficacy. But for this young woman in a village in Guatemala, this gave her life back. Pretty incredible. So it's important, too, to know when a movement is truly abnormal and when it's just a variation of normal. We have to know when to be able to reassure, when they really require more testing, and when they might need some treatment. And honestly, this is another area where just spending a lot of time with healthy kids gives you such a great perspective, an essential perspective in treating kids who are ill. So let me show you an example. So this is a young girl who, anytime she's excited, flaps her hands. And her younger sister's in the bath, and she's having a ball and loves it, and so she's flapping her hands. So this is the same young girl a few years down the road. Blew my mind. So she's just so excited, and that's how it comes out. Well, all of us have seen kids who hand flap. We all have in our minds an idea of what that means. And I'll tell you that the younger sister, she lines up everything. She lines up her Beanie Boos. She lines up her stuffed animals. She lines up her My Little Ponies. And the second younger sister does the same thing. She lines up her snacks and eats them in order. So I'll tell you, this is getting pretty worrisome, right? Hand flapping and a lot of lining up. Well, the most worrisome feature of this child's presentation is the family history. And this is a child whose most abnormal thing is who her dad is. It's not a normal thing for a 7-year-old to be able to recognize the sagittal from the axial view on an MRI. And so having a neurologist as a dad, it definitely predisposes you to a lot of things. But I can assure you that the hand flapping kid and the lining up kids, they are entirely normal, except for who their dad is. So stereotypies are something that we see in all sorts of kids, both with developmental delay, with autism, etc., and in the normal population. So it's actually 40% of typically developing children at some point in their development will have a stereotypy. Now, sure, it's far more common in kids with developmental delay, but it's not at all isolated to the developmental delay population. In stereotypies, the movements do evolve over time, but maybe it goes from being a head bob exclusively to more of a head rotation over time, but it's still sort of the same core of features that are preserved over time. Unlike a tic, where there's a clear evolution in time, nature, and space. So stereotypies are almost never distressing to the child. The child never comes to you and says, I am desperate to stop my stereotypies, please help. It's that the child doesn't even notice that they're having them, and the parent wants you to stop them. My favorite chief complaint of this was a high-pressure mom who told me, how is he ever going to become a trial attorney if he does this all the time? The kid is 9. The kid's 9 years old. So if the parent is seeking treatment for the child and the child doesn't care, my opinion is that the right thing to do is to side with the child. And this is a circumstance where most individual stereotypies do learn to suppress them over time as their executive functioning is maturing. Most of us who have had stereotypies along the way have learned that there are times to do them and times to not do them. And most kids outgrow them. But again, as I'm sitting around departmental meetings, I still see plenty of my colleagues still doing their stereotypies. So, in summary, capture a video whenever you can. You'll always be glad to have a record of it, whether it be you who slows it down and measures the tremor or sees the evolution of one body part to another or recognizes that it's not just myoclonus, it's dystonia as well, or if you send the video to somebody like me, it's great to have a video. If you can organize the patient in a hierarchical fashion, first pinning down the phenomenology, then getting the distribution and timing, and finally making yourself a limited differential, iteratively working through that, I would say 9 times out of 10, a general pediatrician or a child neurologist can get to the right diagnosis using this iterative process. If you learn to recognize when a pattern of movement is common and abnormal by adult standards, but not abnormal for a child, versus truly pathological, key distinctions. Thank you so much. I appreciate your time. Yes, ma'am.
Okay, so it's about my son. My son, he's 14 now, but as an infant, when he got excited, we were holding him. He would do like the Superman move. We would hold him up in our hands, and he would go like this, and then it would resolve, within 45 seconds.
Okay.
Outgrew that.
Okay.
He has tic disorder now, but
Okay.
what do you think?
I think anything that a child outgrows and that you only can tell about in retrospect is probably a benign thing. So
we
the
figured at the time, like, there's
Yeah.
nothing else wrong with him. So
yeah, and I can tell you, with every diaper change, I was doing neurological exams on all 3 of my kids, and I managed to not screw them up on that axis yet. So, but that temptation to see something that is a little strange as potentially pathological really, just requires seeing them over time. And if you're seeing the same movement over and over, and their development is otherwise following perfectly, I think it's safe to watch.
what would you call it though? Like, I see it in my niece now too. But
Yeah. So it's this sort of movement.
it was a twisting.
Yeah, and it was repetitive.
Yeah.
So
he would do it not infrequently when we held him up, do the Superman move, or
Yeah.
that was usually the only thing.
So that's not one of the canonical reflexes. Was he born on time?
37 weeks.
Okay, so that's probably a stereotypy. And if you saw the same movement over and over, it started within the first 3 years of life. It eventually evolved away. That's likely a stereotypy. So, Sir?
How much is speech involved in these disorders?
So with the dystonias in particular, you can have lingual dystonias. And one of the key things about distinguishing those from, say, just a speech apraxia or dysarthria is that a person can have great difficulty speaking but might be able to sing, or can say things in a repetitive way, like they could say a quick repetitive poem. But speech is really only involved with dystonia, and if someone has a severe tremor, that I've never seen in kids, but if an adult has a severe tremor with like head titubation, you can have a tremor involving the voice. But I've never seen that in a kid. You don't have. I have seen tremor. I have seen tics affect speech because the person had an inhalation tic, so they were constantly doing this sort of motion, and that affected their speech. But that's really that the speech is being flattened by the disorder, not that the disorder is sort of interposing within the speech. So it absolutely can affect speech, but it's not that common.